Hey guys, welcome back to my channel, and for today's video, I'm going to share some more things about recovery practice. So if you are planning to become a recovery nurse, or if you are working in the ward and you are interested to specialize in recovery or in theaters, this might be a video for you. Alright, so at this stage, I'm sure that you know that nursing is a broad field and nurses work practically everywhere. Perioperative nursing by itself is a broad field. You can go to scrub, anesthetics, or recovery. So if you decide to work in the UK, it's either one or the other, but sometimes in some trusts like mine, you may even work in all of these areas. So if you decide to work in recovery, these are the good and bad sides of this area. Before we begin, please click like and subscribe so that every time that I post a new video, you'll be updated. Let's start with the good side. Number one, recovery nursing is a specialized nursing field or a specialized field of practice. So the good thing here is you develop a specific set of skills, a particular set of skills that you cannot apply to anywhere else. In other words, you don't need to worry about other types of skills. So in my experience, although I haven't worked in recovery for a long time, what I can say is that early on in my practice and training, I was encouraged to develop my assessment skills, especially primary and secondary assessments. I'm talking about the A, B, C, D, E again and again. The reason why they call it recovery is because you recover patient from the effects of the anesthetic. Your skills in recovering a patient from anesthesia, making sure that his airway is protected, his breathing is adequate, his circulation is stable, etc., etc. And the secondary skill is how to manage pain in a non-pharmacologic and a pharmacologic wise. You also have to develop this skills in preventing the post-operative complications or risks, things that could happen after a surgery. The bad side of working in recovery or in any specialized areas of nursing in general is that you lose the other sets of skills. Like for example, it's very rare to cannulate or start an IV in recovery unless the patient was really restless and then he will pull out his contraptions. It's also rare to have venipuncture because most of the time, if they need a blood sample, they'll do it in theater, or if you need an arterial sample, we just draw it from the arterial line. So not many punctures happen in recovery. Also, unlike in the ward, we don't feed our patients through an NGT. In the UK, patients who are recovering from anesthesia in the first 30 minutes are allowed to eat and drink, but we're not going to feed them proper meals. So what we usually offer in recovery is a cup of tea, coffee, and some biscuits, and the usual cup of water. So we usually encourage the patients to drink as soon as they're fully awake to aid in their hydration. Unlike in the Philippines, where we usually provide hydration through IV fluids, in the UK the best form of hydration is oral hydration or oral fluids. And another skill that you might not be needing is catheter management. So for example, obtaining a urine specimen from the catheter or performing a urine dipstick, which I've heard they do it in the ward, but in recovery in the UK we don't. And of course, removing an indwelling Foley catheter. The only skill related to catheter in recovery would be insertion of a catheter. Even this one is pretty rare because they usually insert the Foley in theater. In my 6-month stay, I had only witnessed insertion of a straight catheter or an intermittent catheter twice. Second good thing in recovery is that we don't have drug rounds as the ward nurses do. So this means we administer less medications. Sometimes we don't even administer them. So most of the drugs that we give in recovery are stat doses or PRN doses. If a patient is still in recovery and several of his medications fall under due time, then we'll give it as long as it's not contraindicated. The number of medications that we give in recovery compared to the ward is significantly less. So the bad side of this is that you'll get less exposed to a variety of medications. Like for example, when I floated in one of the medical wards, I had to support the nurse with her drug rounds. I was looking at the prescription chart and I'm not familiar with some of the medications. I'm more familiar with like painkillers, antibiotics, anti-inflammatory, and blood thinners. But other medications I'm not familiar with. I can't even recall the names of the medications that I saw in the prescription chart. And because we administer less amount of medications, sometimes it can become routine. Like I've had one day wherein the only drugs that I've given were fentanyl and paracetamol, and that's it. For the entire day, I had 3 patients and those are the only 2 drugs that I gave. So the tendency is you tend to forget the other types of medications. It's not really a big deal to recovery practice since you have the BNF or the Medusa as your reference guide, and you can always ask the physician or your colleagues for help. third good thing about working in recovery is that there is a short and quick turnover of patients. I've mentioned to you in the previous videos that in recovery, the patient comes in from theater and stays with us for 30 minutes, and then we will transfer or shift the patient to his ward or to his room. It's a good thing because there's a lesser paperwork and you have to monitor the patient 4 or 5 times, and then you shift. So that means you can focus on other things like your clinical assessment, your nursing notes. You can actually write a better nursing note with that kind of time. And if you are an introvert who is really shy or who's not really good with talking or speaking to clients, this could be a good thing for you, because half of the time, like 15 minutes, the patient is still asleep or semi-conscious, so you don't really need to talk to them at this point. The bad thing of having a quick turnover though is that, number one, you don't get to know your patient well. There's only limited time of you talking to the patient, not unless if, for example, there's something came up that prevented you from shifting the patient soon or earlier. Also, because we don't have the same patient. I mean, as soon as we shift the patient to the ward, we'll never see him again, like most of the time. The disadvantage of this is that if you're a person who entered the nursing profession because you wanted to help people and you wanted to see how they improve, how they progress, well, you'll definitely not see that as a recovery nurse. Because of a quick turnover and you have to shift the patient to the ward ASAP, you have to finish the documentation in a little amount of time. This only becomes a problem when the patient arrived in recovery with a supraglottic airway, like for example an LMA. So generally, while there's still an artificial airway in situ, we tend not to leave the patient at all costs because anything can happen, and this could compromise the time you could do your paperwork. It's always a matter of strategy, how you be able to write while the patient is still asleep. Well, that's something that you need to learn. That's something that you need to develop as a recovery nurse. Fourth thing that is good with recovery is that because of the 1:1 ratio, you can actually talk to your patient if you have time. Like, you can talk about a lot of things, especially if you've given an opiate or an opioid painkiller. We usually add 30 more minutes to the recovery of the patient before sending him back to the ward. And this gives us time to finish all the needed paperwork and to get to know our patients, albeit in the short period that a patient stays in the hospital. So I find this a positive thing, especially if you are an extrovert or if you are a person who loves talking to his patient. I really like conversing with my patients because sometimes they tell funny stories and sometimes I tell funny stories to them, and it gives me this satisfaction wherein I can see the patient is comfortable, the patient is happy, the patient is laughing at my jokes. The disadvantage though is that sometimes, especially if the patient had general anesthesia, the patient will be repetitive in his questions. Like, he would ask you again and again, well, what happened to him? How was the surgery? Was it a keyhole surgery? Did they find tumors or stones? Although you have explained these before, the early minutes of your conversation, you'll find that some of them becomes repetitive. We understand the reason for the repetitiveness, and sometimes the patient is also confused. I've had patients who say that they are in pain, but actually I don't think they are. And sometimes they even respond to your questions in a silly way. Like, I've had this patient who I've asked, "How are you feeling?" And he said, "I'm fine. Yeah, I'm good." And again, "Are you in any pain?" "Yes." Okay. "Are you comfortable?" "Yes." "Are you in any pain?" "Yes." "I thought you were not in pain." "Yes." So yeah, you'll see those kinds of scenarios while working in recovery. Sometimes it gets funny though, but I enjoy it. I enjoy every conversation that I have with my patients. And the fifth good thing that I've experienced working in recovery is that you get this patients from diverse backgrounds. So you have orthopedic cases, bowel disorders, sometimes you get also neurologic disorders such as Parkinson's, patients with diabetes, respiratory illnesses, and of course pediatrics. Although I'm not really a fan of kids, I'm not really particularly good with kids, but because of my job, I have to be more friendly and more attuned to pediatrics. Pediatrics is a bit of my Waterloo. I don't hate kids, it's just that I'm not particularly good with kids, both socially and physically. Like, I remember when I was in nursing school, maternal and pediatric nursing was among my lowest grades. What's something negative about this? Number one, because you don't really know what you can get unless you have a team briefing or you've reviewed the theater list. You may need to have a sort of preparation each time. that every now and then you have study or you have to review your notes or your references on these particular types of disorders or diseases. For example, Parkinson's. I don't encounter Parkinson's every day, so I have to review my notes on Parkinson's. How is it being managed, and what are the usual protocols in Parkinson's, especially with medications. So generally the bad side is you have to prepare yourself in more types of possible situations or possible conditions that you may encounter at work. Unlike, for example, if you work in the ward, if you are in a surgical ward, I just realized this could also be applicable to any types of wards. Well, if you work in the surgical ward, for example, sometimes you have patients with medical backgrounds, although they were admitted particularly for the surgery that they needed. A short video for you. I hope that I've shown you the good and bad side of working in recovery. I couldn't tell you much about it. It's not really a complicated field of specialization, and it's a really enjoyable one. I hope I've convinced you a little in working or joining theaters, especially recovery, because this is really a fun field. It's not as busy or toxic as ward nursing, but it's not as complicated as other fields of specialization, so it's just somewhere in the middle, which is the reason why I like it so much. Thank you for watching, and if you like this video, please don't forget to click subscribe and watch out for my other videos. See you around. Bye bye.